Having diabetes is not the end of the world, right? We have to make some changes. Having prediabetes is clearly not the end of the world, but that's the time you got to hit it hard. That's when you really have the opportunity to prevent diabetes.
Welcome to Baptist HealthTalk, powered by the NAACP, dedicated to improving the health of the Black community through education and empowerment. Hear from Baptist health experts as well as community leaders about what you can do to improve the health and wellness of your family. Whether it's diabetes, heart health, or better nutrition, Baptist HealthTalk aims to promote positive change in Black health outcomes.
Hello, everyone. I'm Dr. Yvonne Johnson, Chief Medical Officer at Baptist Health South Miami Hospital, coming to you from the Baptist Health Studios. We continue this collaboration with the NAACP, dedicated to improving the health of the Black community. Today, our focus is on diabetes, a disease that affects an incredible number of Americans. Here are the most recent statistics from the American Diabetes Association. 38.4 million people have diabetes. That's over 11% of the U.S. population. 8.7 million people are undiagnosed. And 97 million people over the age of 18 have prediabetes. And I bet a lot of you have heard that. That's 38% of the population. That's over a third of us are pre-diabetic. And 12.1% of the non-Hispanic Black adults are diagnosed with diabetes. We welcome Dr. Angel Alejandro, MD, an endocrinologist at Baptist Health, to dive into this discussion. Thank you for joining us today, Dr. Alejandro.
Thank you for having me. It's a pleasure to be here.
So, Dr. Alejandro, in the simplest terms, what is diabetes?
Well, diabetes, simply put, is having too much sugar in your blood. The reason that happens is because sometimes you don't make enough insulin or your body's resistant to the actions of the insulin. The problem is that elevated blood sugar, which is not normal, is what leads to the complications of diabetes. Renal issues, increased risk of heart attacks, strokes, eye issues, and even amputations, unfortunately, in some patients.
Yeah, that was one of the things that my father, who was from the Caribbean, was most concerned about. Diabetes was really prevalent in the Caribbean community.
Yes.
And was so concerned about losing his limb. What causes that? Why is diabetes a risk for losing a limb?
Well, what happens is that diabetes itself increases your risk of cardiovascular disease. What does that mean? Is that you have increased risk of developing blockages in your arteries. You can develop a blockage in one of the coronary arteries that leads to a heart attack. You can develop blockage of arteries leading to the brain, to parts of the brain that leads to a stroke. And with the lower limbs, you can develop blockages of the arteries leading to the toes and to the lower aspect of the foot. And what happens is when there's less blood flow, there's higher risk for infections, and that leads, unfortunately, to amputation risk.
Yeah, that really is a serious complication. So is there a difference between type 1 and type 2 diabetes?
There is. For patients with type 1, simply put, they don't make insulin, right? It's an autoimmune condition where they destroy the cells that make insulin. That's type 1 diabetes. These patients must inject insulin to live, to survive. For type 2 patients, they make plenty of insulin. They make a lot of insulin, actually. But what happens is that insulin just doesn't work the same. Think of insulin as the key to open the lock, right? Our cells use glucose for fuel. That's sugar, right? And in order for that sugar to get into the cells, we need the insulin to open the door. But if that key doesn't work, the sugar can't get in, it can't be burned, and it starts to accumulate in the blood.
I see. And is it usually adults who develop type 2 more commonly?
For the most part, unfortunately, with our issues we're having with obesity in adolescents, we're starting to see more young children or young adults with type 2 diabetes, when in the past you would think of the type 2 diabetic in their 40s or in their 50s. We're starting to see kids under the age of 18 with clear type 2 diabetes secondary to obesity.
Okay, so obesity is one of those risk factors.
Yes.
For diabetes. What are some of the other risk factors?
Well, some of the other risk factors include, sedentary lifestyle, Okay, that's important.
We got to get up off the couch.
You got to get off the couch. Family history is huge. I can speak to that from my family history. I have uncles. My parents have diabetes. That's a risk factor. Having elevated LDL or bad cholesterol is a risk factor. And then race. Race is a risk factor. Being from the Black community or Hispanic, or even from some Asian American communities, and even Native Americans and the Eskimos are at higher risk for diabetes as well.
Okay. So, I hear so many of my friends and family members talk about being pre-diabetic.
Right.
Is that diabetes? What does it mean to be pre-diabetic?
Pre-diabetes is what worries me. You mentioned it earlier. I think simply put, it's 1 out of every 3 Americans has pre-diabetes. Yeah, I myself have pre-diabetes, and I'm the endocrinologist, right? So I clearly know that it's a problem, and it's a personal problem for me. With pre-diabetes, your sugars are high, but they're not at the level of a diabetic. So what does that mean? So to diagnose diabetes, we use the A1C, right? It's a blood test that measures your 3-month average. If that blood test is above 6.5%, you have diabetes. That's it, right? You have diabetes. If it's below 5.7, you're normal. But what happens to that little group like me between 5.7 and 6.4? Those patients, we term them as having pre-diabetes. No, they don't have diabetes, but they're at great risk of developing diabetes. And as you saw, over 90 million Americans have pre-diabetes. And if we don't make a change early, we don't catch them early, we don't screen for them early, those are the patients that are going to become diabetic in the future.
So if you're pre-diabetic, are there things that you can do to prevent developing full-blown diabetes?
For sure. I mean, number one is going to be weight loss. 5 to 10% of your current weight is what's recommended. That's huge. We see that now with all these newer medications that we have that promote weight loss. Those patients have less risk of progressing to diabetes because they're losing weight. Diet is key as well. We got to change the way we eat. I have to change the way I eat. But it's hard sometimes.
It is.
It is hard. And it's hard when they limit the food that we're used to eating. And sometimes they want to eliminate it completely. And that's where I come into play. And I tell them, listen, it's about moderation. Yeah, you can have rice, but maybe don't have as much as you used to, or not have it every single day. Or if you're going to eat rice, then don't eat bread that day. Limit yourself to 1 carb. So we use the plate method where we divide the plate, and our nutritionists here at Baptist are great at educating our patients on diet and what we can do to allow our nutrition, which is something we can modify sometimes, allow that to prevent the progression of diabetes, or in the pre-diabetic state to prevent diabetes, period.
Yeah. So I think that's really important, because I know I've talked to a lot of patients, particularly African-American patients, who have it as a way of saying, doc, I'm not claiming it. You tell them, I'm worried about diabetes. Doc, I'm not claiming it. So it really sounds like it's important to kind of claim that pre-diabetes so that you really can do something about it, not to develop the full-blown disease.
I agree. I mean, I like to win the game, right? I like to win. We all like to win. But you have to have a game plan, right? And when you see that pre-diabetes, we can't blow it off. We can't just say, hey, listen, you're pre-diabetic, but you don't have diabetes, you're good to go. No, you're not good to go. You're pre-diabetic. We have to prevent diabetes, especially in the Black community. I mean, it's 3 times risk for a member of the Black community to end up with end-stage renal disease. 3 times greater risk than the rest of the population. Right. And you mentioned amputations, it's 2 times greater risk. So it's a very high-risk group. And I think that's a red alarm, a light that we can't ignore. And sometimes, we put it off. We say, listen, we'll see you in 6 months, diet, exercise. No. That's the time to hit it hard, to lock in, and try to see how we can prevent that patient from developing diabetes so that we reduce their risk of complications moving forward.
Yeah, it sounds important. So, if you actually haven't been diagnosed with diabetes or even pre-diabetes, but you might have some concerns, what are some of the symptoms that, you would look at to make you say, I think I need to go and see Dr. Alejandro and find out if I might have an issue?
Well, there are some classic symptoms, right? You can have excessive urination, excessive thirst. You can have weight loss. You can have blurry vision. But sadly, sometimes there's no symptoms and you simply have to screen. You have to check. And if you're part of a high risk population, then you got to put the effort in to check. Ask your doctor, your nurse, your provider to check an A1C. It's just a blood test. But some people just don't have symptoms. There's data suggesting that when you make the diagnosis of diabetes, you may have had it years earlier, 2 to 3 years earlier, and just didn't know.
So you were talking about, how a lot of Black people are at higher risk for certain symptoms or sequelae of diabetes. Are there any genetic or biological factors that make Black people more susceptible to type 2 diabetes?
There are. And these are recent developments. For example, there's a gene called the G6PD gene. Don't worry about the gene, but there's a gene. There's some chromosome abnormalities that have been identified that can increase your risk if you have African ancestry by about 30% from the general population. So there are genetic factors, but it's not genetics alone, right? There's environmental factors as well. And that's something that combination is what can lead to trouble. You're at a predisposition, you're at a high risk group, and then you have other environmental factors. Could it be access to healthcare? Could it be you don't have access to healthy food options? You don't have the ability maybe to pay for the labs or for the screening? I mean, those are environmental, socioeconomic things that make things even worse.
Yeah, I think these days we call those social determinants of health.
Yes.
So you hit that nail right on the head that, for a lot of patients, just being able to get to a doctor,
right.
Whether they have insurance or if you have insurance, having transportation to get to a doctor. Or, once you come and see the doctor and you give them a prescription, how much do those medicines cost that so many people are on for weight loss these days?
You're right. They're thousands of dollars per month.
Right. Right. Yeah. So that certainly could be a barrier to a lot of people. You also mentioned another thing that I think is a barrier, particularly for, a lot of African-American patients and I think probably Hispanic patients as well, is, our typical diets, a lot of the historic diets that have been part of our culture, with the rice and, cornbread and, potato salad and, fried foods, a lot of the typical foods in our cultural diets may lend themselves to diabetes. Are there ways in which we can manipulate or modify them that might help?
Yeah, I mean, if you think about myself and my Puerto Rican, and in my family, the matriarch is the one who cooks the meal, right? My mother was the one who made the meals. My mother cooks for me, for my brothers, for everybody. But sometimes it's the matriarch that has type 2 diabetes, right? And they are the ones providing the food down the chain. So what happened in my family is my mother had to make a decision, right? She had to change the way she cooked so that it affected not just her positively, but down the stream, right? So she stopped using so much salt. She stopped using that much rice. We use different kind of oils. And that actually it's amazing to think how in our community, one little change on the top can trickle its way down and help me, my father, my brothers, my kids, her grandkids. Those are things we need to do. Education. Sometimes we don't realize that it's our diet that's affecting us. And we don't realize that we don't have to eliminate everything that we love. Maybe just a little bit less, maybe not every day. And it makes a huge difference for the entire family, not just for one person.
I think that's an important thing, that fighting disease needs to become a family activity.
Right.
And, I love to tell a story. I did a little bit of primary care in my day. I've mostly practiced emergency medicine, but I had a patient who was the matriarch of her family. I was treating her for diabetes and high blood pressure. And then her son came to see me as a patient. And as I'm taking his history, I ask him, is there family history? And he says, for diabetes, high blood pressure, anything, I'm kind of going down the list. Nope. And I'm thinking, Now, I know that's not true.
That's right. You're missing one person in particular.
Because I take care of your mama.
Right.
So I know
Right.
this is in your family. And of course, I could not disclose to him that because I'm obligated to keep her privacy, her medical care private. But I spoke to her and I said, you know, your family is at risk of the things that you have. And I think it's important for you to share with them the things that they don't know so they can start taking, you know, some action now not to develop those. And I think that's perfect, that story that you tell about, you know, your mother and you know, as a representative of, you know, kind of the matriarchs of our families who are responsible for not just cooking, but educating the family, you know, about their health.
Right.
So
I agree.
that's
I
really
think I've well said with your patient that you took care of the son. I mean, but you know, I got to tell you, it's if you start at the top, and I always tell my patient, I'm planting a seed today, right? I'm letting you know you have pre-diabetes. I'm letting you know what we need to do moving forward, and then you plant that seed and then let them water it. And sometimes you'll be pleasantly surprised. All of a sudden, now the husband comes in to be seen, the son comes in to be seen, everyone comes in to be seen. Because they all start helping each other out and they all become more aware of the possible complications of diabetes. So little steps, but they go a long way.
Okay. So, you know, you mentioned some of the complications, you know, and we talked about kind of losing your limbs, but you also said something about heart disease and strokes. And, you know, can you kind of elaborate a little bit?
Yeah. So, diabetic patients die of cardiovascular disease. One out of every 2 patients with diabetes will die of either an MI or a stroke. I mean, those are sobering facts, but they're facts. That is the biggest endpoint, I guess, is to avoid a fatal MI or a fatal stroke. But you can't also fail to mention how important it is to protect your eyes from the retinopathy, right? When your eyes bleed because of the high sugar, or you have impaired kidneys because of the high sugar. Or even when you have that neuropathy, which is annoying, right? It's that burning feeling at night, the numbness. But remember, that sometimes leads to amputations. Maybe you don't feel that wound on the bottom of your foot because of that numbness and the tingling. And before you know, you have a big ulcer, and then things are out of control.
So I guess those diabetics need to check their feet.
You got to check
Just
your feet.
Got to look at them.
You got to wear white socks. So then when you take your white socks off, if you see blood or any kind of secretion, then you have something going on. It's hard to look. I have trouble looking at my feet. It's not easy. But wear white socks. Use a little mirror. But the white socks helps because if you look at your socks at night and there's something on it that shouldn't be there, then you have to delve a little deeper and look for that little wound or that little infection.
So you also mentioned about the kidneys. Does it play a factor? Diabetes play a factor in patients having to go onto dialysis?
Oh, yes. And that's the biggest fear of most of my patients. When you tell them they have diabetes, the first thing they tell me is, I don't want to end up on dialysis. I have a family member who ended up on dialysis. Diabetes clearly affects the kidney, so does blood pressure as well. But that's something that we monitor. We check the urine every 3 months. We look for protein. We look for microalbumin. I mean, there's a lot of things we can do, but you got to look. You have to check. And once you see you're spilling a little bit of protein, there's things we can do now. We have plenty of new medications that are quite effective in delaying progression to end-stage renal disease or dialysis.
Yeah, so you've given us quite a few reasons for claiming it.
Right.
For actually looking to see, do we have diabetes? Are we pre-diabetic? Do we have it? Because it seems like it is not a sentence to ending up on dialysis. It is not guaranteed that you're going to lose your eyesight or, you know, lose a limb. Seems like there's a lot of things that you can do to modify the illness and prevent some of the feared sequelae.
You're absolutely correct. And what I try to instill in my patients is hope, right? Having diabetes is not the end of the world, right? We have to make some changes. Having prediabetes is clearly not the end of the world. But that's the time you got to hit it hard. That's when you really have the opportunity to prevent diabetes. And that's been my passion. It's 90 plus million people with prediabetes.
Yeah.
We need to focus on those 90 million so that they don't become an added statistics to the 34 plus million patients with
I have
diabetes.
to tell you, that was a shock for me to hear, more than 30% of our population
it's 1 in 3
has some risk of diabetes. So, what are some of the preventative measures that families can take to reduce diabetes across the generations, particularly in Black households?
Well, we mentioned earlier about diet. We talked about that. Increasing physical activity. It's just as simple as walking. 30 minutes most days is very helpful. Diet, we mentioned. Blood pressure control. A lot of these things, man, it's a terrible cocktail when you have high sugar, high cholesterol, and high blood pressure. That's a triple whammy that you don't want. But I think the biggest thing is just diet, exercise, weight loss. Tell my patients, listen, losing weight is hard. I know it's hard. I've been big most of my life. But step one is I'm not going to gain any more weight. Step two is I'm going to try my best every month to lose a couple pounds. And if you do it that way, you can maintain it. But you got to get the weight off, because I can tell you from experience, when the weight's up there, A1C follows it. And when the weight comes down, A1C comes down, and you feel good and things start changing and start turning around. Yeah.
So what are the screening processes for diabetes?
Well, for diabetes right now, what we're using is the hemoglobin A1C, which is a 3-month average. What it measures is the amount of glucose that sticks to the red cells. Red cells live 3 months. It's a 3-month average. That's the easiest screen that we have. Now, in order for it to be used for diagnosis, it has to be a blood draw, a venous blood draw. You can't stick your finger and get an A1C off one of these machines. We used to do oral glucose tolerance tests, but those are cumbersome. We have to come in, measure your sugar, drink a sugary drink.
Coke.
Exactly, and come back in 2 hours. And that doesn't fit in most patients' lives. But the A1C is a simple blood test. It's all we need. And that'll tell you where you are. If you're less than 5.7, congratulations, you're good. If you're above 6.5, that's okay. You come see me. But if you're between 5.7 and 6.4, that's when you got to focus, because you want to do whatever you can do to keep it below 6.5.
Got it. So, I have heard and seen those patients who have diabetes who now have a lot of different kind of monitoring. I know it used to be that you had to stick your finger and, put the little strip in the machine and all of that. And now it seems like a lot of patients have self-monitoring. It's attached to their smartphone.
Right.
What are some of these newer monitoring devices?
Well, these are called continuous glucose monitors, and these are game changers. Studies have shown that just by using one of these devices, you can lower your A1C 1% without making any changes to the medication. Now, why is that? Because you see how your body's reacting to food. You see how your body's reacting to stress, and you make changes. It's real-time data. There are 3 different types of monitors, and there's even one right now that's available without a prescription. All you go to their website, you order it, you pay your fee, and it lasts 15 days, and you get 2 per month. And if you're concerned, then reach out and find one of those monitors, because it really, really helps you see, at least for a little while, what's causing your sugar to go up. Maybe it's not the rice. Maybe it's the noodles, But if it's the noodles, you got to eat less noodles. So
okay.
it works.
I like having that kind of control over
It's amazing.
the situation. That helps. Now, you said something that we hadn't really talked much about yet, that stress can play a part in your sugar.
Oh, for sure.
Tell us about that.
So we know that our bodies make hormones, right? I'm a hormone guy. I'm the hormone doctor. And one of those hormones is cortisol, which is like prednisone or dexamethasone. And we know what happens to the body when you take steroids, your sugar goes up. So in times of stress, your body makes more cortisol, and that'll raise your sugar. And I tell patients that it's true. And the husband looks or the wife looks over, but it's true. Stress will increase your sugars. There's no doubt about it. And if you're wearing a monitor, and it's funny because these monitors tell you your sugar is going up, and then it asks you what happened. And one of the choices is stressful event, So it's clear. Stress can raise blood sugar. There's no doubt about that.
Okay, well, that's important to know, that we need to look into some ways of helping to reduce our stress.
Yes.
And maybe that exercise, that walk that you talked about is a good way
Hearing the little birds
kill
sing.
kill 2 birds there.
That's right.
Is type 2 diabetes reversible?
It is. And that's why I never want to tell patients there's no hope. You can reverse this. We all make mistakes. We go down the wrong path, but just put it in reverse and you can go back and you can reverse this. But you have to lose the weight. Okay? If you don't lose the weight, there's no way to reverse this. If you remember back in the day when gastric bypass surgery was so popular,
Right.
and to the point the surgeons were saying we can cure diabetes. Well, they weren't wrong. They weren't wrong at all. By losing the weight, the sugar goes away. What happens, however, 5 or 6 years down the road when the weight comes back? The sugar comes back. But if you can lose 5 to 10% of your body weight, you can prevent diabetes. And in some cases, that 6.5, which made you a diabetic, you can get it down below 6.5 and go forward.
Okay. So, you touched a lot on some of the social determinants of health, access to healthcare. What about things like education or income? How do those impact diabetes?
Well, in certain communities, we know that income's a big deal. Poverty. Eating healthy is not cheap.
Yep.
And I, as a provider, I understand that. Sometimes that's what you got to do. I mean, you have to eat somehow. And if the $1, $2, $3 menu is cheap, but it's not the best meal.
Right.
And that's something we need to do something about. Eating healthy is just not cheap. And that's unfortunate for a large portion of our population. That being said, moderation, You don't eat the large fries, buy the small one, right? Enjoy a Happy Meal. And it's funny, if you look at the calories in a Happy Meal, it's much less than a number one, which is the Big Mac, right? So, we do what we have to do. But when you go to a fast food place, or the place that is maybe not the healthiest meal, and find a way to make it a little better. Don't get the double cheeseburger, get a cheeseburger.
Gotcha.
Right? Maybe skip the fries and just, drink water or a diet soda. I mean, you'll never see me complain if you order a diet soda. That's fine. But just don't order the regular one, right? Water, walk it off, You go outside, walk a little bit after you eat something may raise your blood sugar. So it's hard.
Yeah.
It is very hard.
It is hard, but I appreciate the fact that you've given us some really practical ways of looking at it, of kind of taking a little bit of control in managing or limiting the unhealthy diet, having less of that. And I know that Baptist has sponsored some farmers markets where you can get out and get some healthy food, fruits and vegetables, and those really make a difference. Let me ask you this. Fruit, I grew up thinking is something very healthy. And then I've heard some diabetics say, well, it's too much sugar. I shouldn't eat fruit. Tell us, what's the real story on that?
So you got to be careful with the fruit. Fleshy fruit, such as a pear, pineapple, mango, it just has too much sugar. You're going to have to eat very little. But it's okay. Listen, go for the small fruit. That's what I always tell them. Grapes, blueberries, strawberries. Okay, they're very tasty. And the smaller the fruit, the better it's going to be for you. Okay? Be very careful with pineapple and mango and pears. It's just too much. And listen, you can eat an apple healthy, fine, but don't eat the big apple. Get the little one.
Gotcha.
And then go from there. But yeah, the small berries are if I were to suggest something from my diabetics, would be those blueberries, raspberries, strawberries, grapes. The small fruits are better.
Size matters.
Size doesn't matter.
Okay. Dr. Alejandro, I really appreciate you coming on today and joining us in the hopes of educating and empowering our listeners. I think you really gave us a lot of food for thought has been very empowering, where people can make good choices. Be sure to download this and our other Baptist Health podcasts to keep up with the latest health and wellness information and tips from our experts.
Find additional valuable health and wellness information on our resource blog at baptisthealth.net/news. And be sure to interact with us on our social media channels for live and upcoming events. Baptist Health Talk NAACP edition is brought to you by Baptist Health, the warmer side of care.